Okay. Third case is a female, 37-year-old. She was diagnosed with CML in chronic phase in 2017, and she had comorbidities of hypertension, for which she was put on indapamide, and morbid obesity. At the time, she was 155 kg. Her SOCA and EU LTS score were intermediate. She was commenced on imatinib, which was what was readily available then, at 400 milligrams once a day. But her BCR ABL monitoring was erratic due to the expense. She failed to achieve complete hematological response after 6 months of commencing therapy. The dose of imatinib was increased to 800 milligrams once a day, but it was later switched to bosutinib in August 2017 due to inadequate control. She was having leukocytosis. She wasn't very compliant on bosutinib. Um, Her BCR-ABL levels rose while on bosutinib from 57% to 97%. She was sent to do a TKD mutation analysis in February 2022, which showed no mutation. She was then switched to nilotinib, 400 milligrams BD, in April 2022. On nilotinib, her PCR after 8 weeks was still 90%. She was switched to asciminib, 40 milligrams BD, which is 80 milligrams daily. And the PCR initially, she responded, the PCR ABL initially dropped to 50% and then rose to 80%. Cytogenetics, she had a bone marrow done with cytogenetics, which revealed a normal karyotype of trisomy 8, duplicate 17p, variant Philadelphia translocation. She had NGS, which was ASXL1. Patient was now classified as CML in accelerated phase. Repeat TKD mutations were done, which confirmed G250E and E459K mutations. She was switched to ponatinib, 40 milligrams once a day. But however, she said she stopped taking it due to severe myelosuppression and poor tolerance of the drug. She described the feeling of taking ponatinib as a horrible feeling. She said she felt like she was just going to die. So she stopped taking it due to poor tolerance on her own before presenting in the hospital. Due to her age, she was considered for transplants, and because she had failed multiple TKIs, um, because she was still in accelerated phase and yet to achieve complete hematological remission, she was given 2 cycles of chemotherapy to convert her to chronic phase CML, and then she had a sibling allogeneic transplant. She opted for a sibling allogeneic transplant because she's black and she had the transplant here in the UK in the center I work in. Um, so we felt that. Please, can you hear me?
Yes.
Okay. So so she had a haplo transplant. After transplant, she developed problems in her eyes, which was said to be TB uveitis, query CMV uveitis. She was commenced on systemic anti-TB drugs and also CMV treatment. She's still recovering. She's not yet day 50, so she hasn't been placed on any TKIs. We're still waiting for her to recover her counts. Um, my question is this: she was wondering if there was any need for her to have gone through all the TKIs before the decision for transplant was made. Because I think I know that once somebody has failed 2 to 3 TKIs, the possibility that they respond to the next TKI is low. So I want to know what could have been done differently for her.
Naeem, would you like to lead, please?
Yeah. Okay. So I think the question is very valid from the patient's perspective, but also looked from a retrospective analysis, it's difficult to say that patient was really compliant to the medications, or was there really an intrinsic resistance. To me, it seemed as from the reading it, until unless you gave me the results of the almost like compound mutations in the TKD as well as AXXL1, it looked as if she was non-compliant. And given her, although she's young, but with a morbid obesity, sometimes a lot of centers would consider that as an ineligibility for taking them to transplant. So I don't think there was anything would have been done differently from the beginning, because she went through in a quick phases of different TKIs, whether because she was non-compliant or she had an intrinsic instability other than the BCR-ABL. And we all know that AXL1, by the published data in 2022 in blood cancer diseases by the MD Anderson group, shows that AXL1 itself is independent prognostic, poor prognosis with a score of 4.25. So that itself provides the resistance, and then compound mutations. Once you had that information, you switched the patient to ponatinib, which was perfectly fine, and then gave her some chemotherapy to get the patient to chronic phase. I don't know whether that was really required, but because that was required because of the poor tolerance to ponatinib. But I think that was the right decision to do, and then take her to transplant. So for the question from the patient's perspective, I think it was the chronology of the use of the drug and the tests done, I think, are fine. I would not have done something. I would not have taken her to transplant in the initial phases, because I'm not sure at that time whether she had intrinsic resistance or whether she was non-compliant. So, from my point of view, what was done was fine. Was okay.
Beppe, would you have done things differently?
Yes, no. This has been treated in a very correct way. Also, would say courageous way, because she is. I do not know now the weight of this patient, but certainly this was a problem just to transplant female patients more than 150 kilos of weight. So, and I would say that now I would test if the bone marrow transplantation has been successful. If it's from the molecular point of view, has been cytogenetic, or do you have data or new data or not? Can you hear me? Can you hear me?
Yeah. Yes, we can hear you, Dr. Lendre. Dr. Beppe is asking, do you have post-transplant data on the mutation analysis or the chromosomal analysis or the NGS?
Today is day 21 of her
Okay.
post-transplant. So we're waiting for, we don't do the bone marrow till like
Yeah.
day 30 and then day 100. So she will
So it
still
would be
get it done,
interesting
but
to
she
know.
hasn't done it yet. Okay.
But more than this for CML is very difficult. Can you hear me? Can
Yes.
you hear me? Yes. More than this for CML is difficult to do. After you have done the stem cell transplant, this is of course the late stage, I will say. The only problem that you can add is just if she is able to maintain some, at least for a while, because she has in origin, she had a very, say, bad disease, some kind of not full dosage, but maybe 15 milligram of ponatinib at the moment could be, if she can tolerate every day or every other day, this could be a good option, in my opinion, too. But of course, first of all, I would test, I would check, which is exactly the situation at the moment.
Thank you. Olanre, how does that sound?
Yes, sounds like a good plan. Thank you.